Clinical chemistry, adrenal hormones. The adrenal gland produces steroid hormones and neuropeptides that are essential for life. Conditions affect blood pressure and electrolyte balance. So hypofunction is treated with exogenous hormone replacement. If you look at that stem again, hypo means less. So you would supplement with exogenous hormones or hormones that are coming from outside of the body. Hyperfunction, hyper means more, is treated with pharmacologic suppression or surgery. The anatomy, it's composed of an outer adrenal cortex and an inner adrenal medulla, and each component produces unique hormones. It's pyramid-shaped, located just above and medial to the kidneys. Arterial supply is symmetric. Axons reach the medulla through the cortex. So here you can see the cortex on the outside, the medulla on the inside, and then it's sitting on top of the kidney. The zona glomerulosa synthesizes the mineral corticoids, also known as aldosterone, and that's critical for sodium retention, potassium, and acid-base homeostasis. The zona fasciculata synthesizes glucocorticoids, glucocorticoids meaning cortisol. And the zona reticularis synthesizes DHEA, which is the androgens. Cortex steroidogenesis. So steroido is referring to steroids, genesis is the creation of. So all adrenal steroids are derived by sequential enzymatic conversion of a common substrate, cholesterol. Only free cholesterol can enter steroidogenic pathways in response to ACTH. ACTH is adrenocorticotropic hormone. Adrenocortico is talking about the adrenal cortex. Tropic is a hormone that's released in one spot and acts on another endocrine gland. Hormone. Conversion of cholesterol to pregnenolone is a rate-limiting step in steroid biosynthesis. Decreased activity of any enzymes required for biosynthesis can occur as an acquired or inherited trait. Evaluation of adrenal function requires measuring relevant adrenal hormones, metabolites, and regulatory secretagogues. Congenital adrenal hyperplasia, an inherited family of enzyme disorders causing decreased cortisol and aldosterone production. The G cells convert cholesterol to pregnenolone and then into aldosterone. Aldo acts on the kidney to increase blood pressure. Isolated hypoaldosteronism is caused by adrenal gland destruction, chronic heparin therapy, unilateral adrenalectomy, and G-layer enzyme deficiencies. Hyperaldosteronism can lead to metabolic alkalosis, hypertension, and hypokalemia. Metabolic alkalosis, so due to something in the digestive tract, we retain base in the body, so our pH of our blood increases. Hypertension is talking about high blood pressure. Hypokalemia, hypo means less, K is the element symbol for potassium, so hypokalemia is talking about a decrease in potassium. The criteria for the diagnosis of primary aldosteronism is listed below. So plasma aldo or PA/plasmin renin activity greater than 25, low plasma renin that fails to increase with volume depletion, high aldo that fails to decrease with saline or angiotensin inhibition. Diagnosis algorithm. So the tests include urinary potassium excretion, upright PA-PRA ratio, captopril suppression, 18 hydroxycorticosterone levels, adrenal imaging, adrenal vein sampling. Adrenal cortical physiology, cortisol synthesis is critical to hemodynamic and glucose homeostasis. Adrenal insufficiency can be caused by a primary adrenal problem or ACTH deficiency. Symptoms include weakness, fatigue, anorexia, nausea, diarrhea, abdominal pain, and weight loss. Diagnosis is low baseline cortisol levels and ACTH that's greater than 200 picograms per mil. Treatment includes synthetic steroids from G and R zones that are replaced. Hypercortisolism caused by an overproduction of corticotropin-releasing hormone, adrenocorticotropic hormone, adrenal glucocorticoid secretion, and exogenous intake. Cushing syndrome. Cushing syndrome is caused by excess glucocorticoid production or prolonged exogenous steroid use. Determinations necessary for diagnosis: ACTH-dependent versus ACTH-independent hypercortisolism is determined by a two-site immunoradiometric assay for adrenocorticotropic hormone. Pituitary versus ectopic ACTH secretion is determined by a high dose of dexamethasone suppression test. ACTH source in dexamethasone non-suppression: 60 to 70% of patients with non-suppressible ACTH secretion due to high-dose dexamethasone will have Cushing's disease. Inferior petrosal sinus sampling. The source of ACTH hypersecretion can be investigated by simultaneous sampling of blood from inferior petrosal sinus and peripheral vein. Petrosal sinus to peripheral blood ACTH ratio of greater than 2 to 3 is 97% sensitive and is 100% specific for ACTH hypersecretion from the pituitary gland or Cushing's disease. Imaging with CT or MRI is used to localize the pituitary or ectopic ACTH secreting tumors. The outcome for the patients with Cushing's syndrome is similar to that for patients with type 1 diabetes. The diagnostic steps: document cortisol excess, so urine-free cortisol and or metabolites, random plasma cortisol levels, and baseline AM cortisol concentrations. Determine if diurnal rhythm is lost, so late-night values remain high. Determine loss of normal cortisol suppression by dexamethasone. CRH stimulation test to determine ACTH dependency distinguishes the types of disease, so central versus primary adrenal. CRH is injected and then cortisol and ACTH levels are measured. Localization procedures: adrenal Cushing's, adrenal CT, the tumor versus hyperplasia, and adrenal MRI, T2 weighted image to discern the carcinoma. Pituitary Cushing's, pituitary MRI. Ectopic Cushing's, chest CT. Treatment: all types of Cushing's would be treated with surgery, radiation, and or medications to suppress adrenal cortisol production. Androgen excess. So symptoms for boys include penile enlargement, hair growth, and precocious puberty. So puberty happens a little bit sooner. Girls, ambiguous genitalia, hirsutism, acne, clitoromegaly, so enlargement of the clitoris, short stature, and precocious puberty. In women, infertility, hirsutism, acne, male pattern baldness, menstrual irregularities, and virility. Men, infertility, and decreases in the following, so muscle mass, hair growth, testes size, testosterone production, and spermatogenesis. Diagnosis: high levels of DHEAS, DHEA, and testosterone. The treatment includes surgical removal of the tumors or exogenous DHEA. Moving on to the adrenal medulla. So the adrenal medulla secretes catecholamines directly into circulation in lieu of transmitting messages via efferent axons. It acts as first responder to stress within seconds to promote the fight or flight response. Sympathetic cells arise from the primordial neuron crest stem cells, which differentiate into sympathoblasts or pheochromoblasts. Biosynthesis of catecholamines, norepinephrine and epinephrine are synthesized by the conversion of phenylalanine substrates in a tightly regulated manner. Catecholamine degradation. So there's 3 methods of eliminating catecholamine. So we have this fight or flight response, and the fight or flight response is supposed to be very fast, and we need to be able to stop it. So the way that we stop it is reuptake into secretory vesicles, uptake into non-neuronal cells, mostly into liver cells, or degradation. Metabolites and free catecholamines are filtered into the urine and excreted. Urine and plasma catecholamine measurements. Urine catecholamines are assayed using liquid chromatography, fluorometrics, and 24-hour levels are more accurate. Causes of sympathetic hyperactivity: autonomic dysfunction, panic attack, stress responses, drugs, food containing tyramine, and pheochromocytoma. It's a catecholamine producing tumor. Diagnosis of pheochromocytoma: fractionated metanephrines and catecholamines in a 24-hour collection is the best test for diagnosis. Total plasma catecholamines and urine metanephrines, most sensitive screening profile. Plasma metanephrines are measured by HPLC or RIA, radioimmunoassay. HPLC stands for high performance liquid chromatography, touted as most specific and sensitive diagnostic test. Urine metanephrines is possibly the most sensitive urine test. Serum chromogranin A and plasma catecholamines. Clonidine suppression test, radiologic localization, so CT, MR, PET scanning. Treatment of pheochromocytoma is surgery following the appropriate medical preparation. Removal is a high-risk procedure. Catecholamines fall to normal within 1 week of resection. Perioperative alpha blockade is widely recommended. Outcome and prognosis: patients with familial pheochromocytomas are more likely to have recurrence. Long-term monitoring is indicated in all patients. An incidentaloma. Incidentaloma, adrenal mass, typically greater than 1 centimeter in diameter, found incidentally in CT, MRI, and ultrasound imaging of the abdomen. Autopsy studies report frequency of adrenal adenomas at about 6%, and prevalence increases with age. All lesions should be assessed for malignancy or hypersecretion. Surgery should be considered if adrenal mass is cancerous. Autonomously secreting cortisol, aldo, or catecholamines greater than 4 centimeters in diameter, or if it's growing.